And he also said the senses and intellects being uninjured. Well, I just mentioned in the first few slides that patients with Parkinson's disease can frequently get dementia. Okay, maybe 75% or more of them can get dementia if they live long enough with the disease or are older. So he was wrong on that one. Now, in 1817, your life expectancy wasn't too great. You may have lived to the 40s or so on the average, whereas nowadays, men probably live to age 75 and women live to about age 80. Also, the senses, he thought, were uninjured. However, we also know that as a part of the non-motor features of Parkinson's, the senses are affected in multiple ways: olfactory deficits, visual deficits, etc. Even some trouble with sense of taste in some patients. Well, also in his manuscript, he talked about some other non-motor complications that he hit right on the head. In this stage, the sleep becomes much disturbed. The bowels, which have been all along torpid, now in most cases demand stimulating medicines of considerable power. The expulsion of feces from the rectum sometimes requiring mechanical aid. So he's talking about disturbed sleep. Disturbed sleep probably occurs in about 90% of Parkinson's patients at some point in the illness, so he's right on about that. And constipation can be one of the earliest features of Parkinson's disease, even before the motor symptoms begin, and can be a prevalent problem for patients requiring treatment with numerous medications throughout the disease. Mark for the animation. So Parkinson's is a diagnosis that depends upon the motor symptoms. Right now, we're not adept enough or cognizant enough, probably, to diagnose Parkinson's based upon non-motor early symptoms like loss of olfaction or constipation. We're working on that, however, and I'll talk about that some later. But the loss of dopamine-containing neurons in the substantia nigra here in the midbrain is what helps us make the diagnosis of Parkinson's disease. This is a cross-section of the midbrain of a control patient, a normal patient, that has nice substantia nigra or black substance present there. These pigmented dopaminergic neurons that you see in this photograph here on high power are contained in this area and make dopamine. Okay? In a Parkinson's disease brain, these cells are lost over time, and you actually have a lot of dropout of these neurons with loss of dopamine as well. 50% cell loss typically equals the onset of Parkinson's disease. So you may ask, when a patient comes to my clinic and they have that resting tremor, how often do you think they actually have the disease going on? We estimate that it's at least 5 years in most cases they've had loss of these cells over time. I saw one recent estimate that Parkinson's may begin 15 or 20 years actually before the patients become symptomatic with resting tremor and other features. So 50% cell loss, maybe 70% dopamine loss, meaning the cells that are still left may not be making as much dopamine as they should be. Well, we talked about dopamine, and everyone focuses on dopamine for the motor aspects of Parkinson's disease and trying to improve patients. A lot of medications that we use, dopamine agonists like pramipexole and ropinirole, vermicryptine, they act directly as dopamine in the brain. Levodopa is converted to dopamine in the brain and replaces the dopaminergic deficit in these patients. You can see that in a Parkinson's disease brain, there's certainly a huge loss of dopamine compared to a control level of 100 there, okay, the dopamine. But other transmitters are also reduced in Parkinson's patients' brains. Norepinephrine, 5-hydroxytryptophan, which is serotonin, medenkephalin, substance P, some other chemicals are increased. So there's not just dopamine changes that occur in the brains of Parkinson's patients. There's also changes in other transmitters. One that's not pictured here that you may find surprising is acetylcholine. The deficits for acetylcholine in Parkinson's patients are actually greater in the brain than those with Alzheimer's disease. And what do we use in Alzheimer's? We use acetylcholinesterase inhibitors a lot to treat them. We also use that in Parkinson's dementia, and I'll talk some about that. But it's interesting that the deficit's worse in Parkinson's than Alzheimer's for acetylcholine. Well, Heiko Brock and his wife and others looked at a lot of brains to publish this paper in Neurobiology of Aging in 2003. Kind of revolutionized how we think about Parkinson's disease pathology and how it starts. But he found that Lewy bodies, the pathological hallmark of Parkinson's, that was on this slide, this little neuronal inclusion body that's made up of alpha-synuclein. He found that Lewy bodies occur typically in certain parts of the brain first in patients with incidental Lewy body disease before they're going on to Parkinson's, and progress over time in different stages of Parkinson's disease. So the first couple places that are involved is the dorsal motor nucleus of the vagus here in the brainstem down here. Also, you see this dark structure here, the olfactory bulb. That fits with one of the two of the earliest symptoms of Parkinson's, which are constipation and loss of olfaction. Don't freak out if you're on the call today that constipation may make you have Parkinson's disease. Constipation is very prevalent out there in society, and it's not always indicative of Parkinson's disease, so don't worry about that. Loss of olfaction, however, unless it's due to sinuses or trauma or some kind of damage to the frontal lower region of the brain, you may want to worry about. If someone has significant smell loss, they may be more predisposed to both Alzheimer's and Parkinson's. We see that in practice. So we think that the disease starts here in the brainstem and ascends and goes up and affects the rest of the brain. Notice the brainstem is more affected by Lewy bodies in this pathology than the rest of the cerebral cortex. The olfactory bulb, though, and the medulla are very strongly affected very early. When does the substantia nigra get involved? Not till actually stage 3 in his staging. So that's why we may have 15, 20 years of symptoms before a patient actually presents. What else is located down here in the brainstem? The locus ceruleus. It's a very important area that's involved in sleep. And patients with Parkinson's can have a condition called REM sleep behavior disorder, where they actually move in the middle of a dream. And these movements can be dangerous for the spouse and the patient, falling out of bed, socking the wife as he's screaming and yelling and trying to get away from someone chasing him. Can happen. Those REM behavior disorder movements can occur 15, 20 years before Parkinson's onset. Well, what are the major non-motor problems in Parkinson's? I've mentioned them, several of them. Dr. Laura Marsh, my colleague who's doing another lecture in this series, is going to cover quite well the major neuropsychiatric changes in Parkinson's disease. I will, however, focus a good bit on the cognitive impairment and dementia aspects of the non-motor problems in PD. I'll talk about some olfactory dysfunction, visual changes, how fatigue is a common part of Parkinson's in most patients, either early stage or later, sensory changes, a lot of sleep disorders. As I mentioned, maybe 90% of patients have sleep problems in Parkinson's, and autonomic nervous system dysfunction, which can occur both in early and later disease. Okay, let's do the first poll question. Which of the following motor and non-motor problems is associated with the most overall impairment in a PD patient? I believe that's what it says. Tremor, dyskinesias, depression, or excessive daytime sleepiness. Anybody else brave enough to respond? We've got one correct answer. I'll give you a clue. All right. The answer actually is depression. Depression is probably in practice, and I'll show you another slide in a second here. One of the biggest features, probably more than the motor symptoms, tremor, dyskinesias, etc. Dyskinesias are actually usually less bothersome, especially for older patients. Michael J. Fox and younger patients are quite aware of their dyskinesias, but many older patients have no clue they have dyskinesias. They can have dyskinesias right in front of you in the office. You can ask them, do you have any dyskinesias? And they're shucking and jiving and doing these twisting and writhing movements that all look like I'm dancing on the screen, but that's what you kind of look like. But these dyskinesia movements, they're not aware of, and they don't bother them too much. Many patients would rather also be on with dyskinesias and moving well versus off and stiff and slow. But depression's the biggie here. And this was shown in a study by Dan Weintraub, who's at the University of Pennsylvania, and others that work with him. But looking at the motor scores on the Parkinson's rating scale, there's a pretty good correlation with quality of life and how someone's doing that you can see there from the motor score, 0.56. However, the Hamilton Depression Scale, the Structured Clinical Interview, Geriatric Depression, they all have similar values to the motor score. How about disease duration? Not as well correlated. How about